Hello all, and welcome to the Caregiver Support Series. Today's episode is another tough subject that I hope I can shed some light on. As someone declines and their body changes, it can certainly affect their brain, regardless of the diagnosis. Sure, the first diagnosis you think of when you're talking about changes in behavior is dementia, but did you know that 85% of terminally ill cancer patients become delirious with behavior changes at some point? Do you know the difference between dementia and delirium? I invite you to sit back with your favorite cold beverage and relax as I explain a few strategies to help prevent troubling behaviors that can arise. As always, please feel free to reach out to me with any questions or topic requests. Words to describe will quickly go over the differences between dementia and delirium, both of which can cause unwanted behaviors that may be prevented or treated. In the education corner, I will explain strategies to prevent those unwanted behaviors and then give a quick nurse tip regarding treatment. Our next episode will focus on revisiting some self-care strategies. The first thing I want to clear up is what dementia is. I think universally that's a word that gets thrown around to describe a lot of different symptoms. Dementia is an umbrella term for a progressive decline in memory. It's not really a disease all on its own. There are many different types of dementia, but I'm going to just list the most common ones. Alzheimer's disease, vascular dementia, Lewy body dementia, and frontotemporal dementia. Diagnosis isn't just based on a decline in memory. There needs to be at least one other cognitive area of decline in an alert person. So that could be their attention span, their orientation or knowing who they are, where they are, what the date is, their judgment or reasoning and decision-making skills, a decline in abstract thinking, which is the ability to think about things that aren't physically in front of you, or personality changes. It takes a thorough assessment and a clinical review of medical history from a physician to decide if one of the types of dementia fits a patient's symptoms. It would also take a physician to rule out delirium before a diagnosis of dementia can be made. Delirium is a rapid onset, a sudden change in condition. It is a disorder of attention, but people who are delirious can exhibit other symptoms, such as short-term memory loss, agitation or restlessness, delusions and/or hallucinations. The other thing that sets delirium apart is that it's treatable and reversible as long as you can find the cause. Regardless of whether a caregiver is caring for somebody with dementia or delirium, it can be extremely difficult and frustrating. The keys to management in either case are prevention, recognition, and reversal before any treatment should be attempted. The best thing we can try to do with a patient with dementia or with a patient who is at risk for delirium is to try and prevent those disturbing behaviors. And there's a whole lot of different ways to go about this. Routine, routine, routine is one of the keys. But here are a few other ideas that could be included in that daily routine. Optimizing sleep and wake patterns. This means that during daytime hours, increase their exposure to sunlight. Keep the blinds or curtains open. The brain is very aware and responds to light versus dark. At nighttime, reduce the light and noise and always provide familiar sleepwear. Orientation. This should only be done if someone is calm. Trying to explain to someone where they are or who they are when they're agitated will only increase that agitation. Sometimes reorientation is just assuring the patient that they are safe. Keep a clock that it can be easily read, and maybe a whiteboard, dry erase board that can be changed daily with the date so that the patient can refer to that if needed. Communication. This seems so basic, but it's often forgotten even by professional caregivers. Make sure someone has their glasses, their hearing aids, and that they're charged, their dentures. Keeping consistent people around whenever possible can also be very helpful. People with dementia may not remember names or even faces, but a lot of times they can still have instincts about how people make them feel. Encourage as much movement and mobility as the person can tolerate, even if that just means passive range of motion exercises for a bedbound patient. Getting into a chair for a bit for someone with a little more mobility, especially for meals, can be very helpful. Get them moving. It's better for their minds and their bodies. Because people with dementia or delirium have trouble expressing their needs, monitoring any symptoms, especially pain, is important when thinking about prevention. Monitoring food and fluid intake as well as bathroom habits can also be very, very helpful. Symptoms such as pain, shortness of breath, constipation, hunger, thirst, etc., can make the patient appear restless and agitated, getting out of bed but not really knowing why or where to go. They communicate non-verbally through their behaviors. So it's important to try and figure out what that behavior may mean. And last, but certainly not least, there are two forbidden words or phrases when trying to connect with a person with cognitive loss. These come from Diana Waugh, who is a local nurse and certified dementia practitioner. She's also a phenomenal speaker. Diana points out that using the word no is like an automatic trigger. No one likes to be told no, especially repeatedly. And when you ask someone with short-term memory loss to remember something, that's like giving them a quiz that they cannot pass. It will cause confrontation and frustration for both of you. Obviously, prevention is not always going to work. In this case, if a person starts exhibiting unusual behaviors, it has to be assessed by a professional. In the case of delirium at the end of life, which is very common, the only reason to treat those behaviors is if they are disturbing or bothersome to the patient, or if they pose a safety risk for the family, patient, or caregivers. Sometimes a delirious state is not bothersome, in which case it may not need treatment. The medications used to treat behaviors can have a lot of side effects, so we have to be very picky. Thanks for watching. This has been an episode of the Caregiver Support Series brought to you by Hospice of Northwest Ohio. Next week's topic is Self-Care Part 2.